So good day and welcome to TLC Academy. I'm Alan Sousie, Director of Nursing at TLC Homecare and Nursing. Today I am posing a question that I believe everyone asks somewhere along the journey of life. What matters at the end of life? As a young nurse, I worked as an oncology clinician, providing experimental cancer treatments and otherwise supporting individuals and families as they coped with dying and death. At the time, I read a book by Stanley Kellerman, an American writer and chiropractor who created the body psychotherapy approach known as formative psychology. Living Your Dying was published in 1974 by Random House, and it examines big dying and little dyings in relation to the shaping of our living, as well as attitudes towards dying, styles of dying, and the styles of living. I found Kellerman's ideas to be profoundly informative, and they definitely urged me to rethink how I viewed the continuum of life to death. As a follow-up to this presentation, I urge you to find a copy of Dr. Kellerman's book and read it. End-of-life care presents many challenges for care providers, clients, and clients' families. Moreover, the care of a dying person must be considered within a holistic context, which includes the psychological, the physical, the social, and the spiritual experiences of a person's life. Foremost in society, we have a growing population of elders who require end-of-life care. Often these elders are prone to loneliness, they frequently underreport their pain, and they have a greater sensitivity to drugs and to drug-drug interaction. Unfortunately, clinicians and caregivers who are responsible for end-of-life commonly lack adequate training to guide end-of-life decisions and to deliver uncomfortable news to patients and their families. They also may face their own discomfort with the notion of death, or we may struggle with not being compensated adequately for time spent when we discuss end-of-life care with a dying person or their family. Some examples are when physicians and nurse practitioners who are normally constrained by clinical time boundaries find themselves in an hour-long conversation with a family. Do they get reimbursed? Do they not? There is a movement today within the Medicare system to try and increase the compensation for such activities. Last and not least, given the unique process of each person's dying, it is possible that protocol strategies for care and treatment will prove inadequate to guide individuals and their families and those who care through the complex and emotionally challenging process that leads to death. As an alternative, I believe that best practice calls for caregivers to be open-minded and as flexible as possible when assisting someone dying. The ability to think outside the box is a superb asset for a caregiver to have. The challenges faced by a dying person are substantial and may be overwhelming. These challenges include physical pain, depression, intense emotional upheavals, the loss of dignity, hopelessness, and the seemingly mundane tasks that need to be addressed at the end of life. An understanding of the dying person's life experience should help care providers to improve their care and to make terminally ill patients more comfortable. Let's talk a little bit about pain. Pain and the fear of pain often motivates end-of-life behavior. In a survey of 310 patients with life-limiting illness, freedom from pain ranked most important in their considerations of the end-of-life process. Pain, especially cancer-related pain, is common. Moreover, it is experienced by 50 to 90% of patients with advanced disease. Fortunately, over 90% of those with cancer-related pain respond to basic analgesic measures. However, many patients fear that their suffering will progress unabated. Although there is no evidence that the perception of nociceptive pain is altered by advancing age, I'll say that again, although there is no evidence that the perception of nociceptive pain is altered by advancing age, the elderly are often unwilling to report their pain because they believe it is a normal symptom of aging and that their pain is directly associated with a worsening of their illness. Nociceptive pain is caused by damage to body tissue and usually described as very sharp, aching, or throbbing pain. While nociceptive pain is commonly and successfully treated with non-steroidal anti-inflammatory drugs and opioids, bodily changes in the elderly demand attention when considering pharmacological intervention. Declines in their renal and hepatic functions predispose elderlies to side effects and toxic effects of medication. In addition, pain is a notable risk factor for depression and suicide, particularly in those at the end of life, and it must be carefully assessed and monitored throughout their care. Another symptom that needs serious attention is depression. Depression, which occurs in up to 45% of terminally ill persons with cancer, has also been positively linked with thoughts of suicide. Older men with a diagnosis of cancer or HIV infections or AIDS and or a history of hopelessness, delirium, and exhaustion are more prone to suicide ideation. The presence and severity of clinical depression are both positively related with the severity of physical illness, and in some, a progressive inability to get out of bed and a decreased appetite may also suggest they have a major depression. Anxiety commonly coexists with depression, and it may be driven by fears of helplessness, a loss of control, abandonment, or pain. When screening for depression in persons with advanced illness, one must consider that anxiety, as well as organic mental illness, could mimic the features of mood disorders. Furthermore, the physical symptoms of terminal illness and its treatment, such as chemotherapy, can generate symptoms of depression. For example, the excessive fatigue, there might be increased sleeping, there may be gross weight loss that are experienced when someone receives chemotherapeutic agents. Assessing and treating persons with terminal illnesses who also suffer from clinical depression not only helps improve their mood, but also enhances their coping strategies, and it promotes their compliance with their treatment. So let's speak about coping. People with advanced illness face the challenge of coping with their disease every single day. While some known as good copers demonstrate optimism, practicality, resourcefulness, awareness, and flexibility, others known as bad copers present with a variety of defensive styles in response to their diagnosis. These more primitive defenses include suppression or isolation of affect, that means they become kind of blank, projection of their feelings, non-compliance, avoidance behavior, they stay away from everybody, and denial, which may be manifest as a deliberate delay in treatment, or as disagreement between the individual and the physician or the caregiver about the presence, implication, or likely outcome of his disease or her disease. When associated with non-compliance, incidents of avoidance and denial are really dangerous. Non-compliance remains the #1 changeable risk factor for unfavorable outcomes in any kind of psychopharmacology. If you don't take the medicine, it can't help you. That's really what it comes down to. Understanding that some people struggle with these feelings, how does that apply to dignity? How do we offer someone at the end of life conditions that are leading to dignity? For the dying, a primary concern is the preservation of personal dignity. Dignity here is broadly defined as being worthy of honor, respect, and esteem. For many people, dignity is directly related to the level of independence they have, or to autonomy retained through the course of their illness. In case studies of 50 patients in an urban hospital diagnosed with advanced stage cancer, Chochinov and his colleagues found that a variety of factors were necessary for preserving dignity in the terminally ill. These factors included functional capacity, cognitive acuity, symptom management, and alleviation of psychological distress. Furthermore, anguish about medical uncertainty, therefore not knowing or being aware of aspects of one's health status or treatment, coupled with anxiety specifically associated with the process or with anticipation of death and dying, worsened a patient's sense of dignity. Another study involving 213 terminally ill patients from 2 palliative care units suggested that loss of dignity is closely associated with certain types of distress common among terminally ill. Examples of this stress are the loss of independence for those confined to the hospital, deterioration of physical appearance, and a sense of being burdens to others. When coupled with heightened depression and a sense of hopelessness, the loss of dignity may lessen a patient's desire to continue living in the face of imminent death. For a subset of terminally ill persons, maintaining a sense of control is central as a task in their dying process. This need for control is prominent among those who request physician-assisted suicides, for example. The most common reason for requesting PAS were a loss of independence, a desire to control the circumstance of death, readiness to die, and the perception of no quality of life, or poor quality of life, at best. Symptoms commonly associated with the request for PAS were pain, difficulty breathing, and fatigue. In addition, wanting to maintain control and not wanting to be a burden on others are important for many individuals. Study of physician observations in cases of those who chose physician-assisted suicide has demonstrated that individuals who choose PAS were universally strong personalities who were determined and inflexible, and they wanted to control both the timing and the manner of their deaths.
That's interesting.
For most of these persons, the request was persistent, forceful, and often accompanied by refusal of any palliative treatment. Regardless of the legality of PAS or a caregiver's particular opinion of it, physicians and nurses should strive to give such individuals as much control over their care as possible to support their coping style and help them maintain dignity. What are some other aspects of dying? Patients who reach the end stage of advanced illness could also suffer from a variety of complications, including anorexia, which is loss of appetite, weakness, gross weakness, and sexual dysfunction. Multiple interacting symptoms contribute to suffering, which is manifested by depression, cognitive disturbance, interpersonal and spiritual crises at the end of life. Furthermore, dying persons and their families often have to deal with complicated practical issues, such as, where's the money coming from? Who's going to pay for home care? Who's going to pay for hospital care? Who's going to pay for the nursing home? And legal issues like organizing a will, finding someone who can be a healthcare proxy. These seemingly mundane concerns can cause a great deal of stress for those who are dying and their families. Physicians and other care providers should be aware of the possibility of these problems and that they may contribute to the patient's distress, and should be mindful of asking about them in conversation. Lastly, in those who are actively dying, therefore, the rapidly evolving process which immediately precedes death, and it can be recognized hours to days before death, discomfort may be heralded by shortness of breath and results in an accumulation of respiratory secretions. It sometimes is very noticeable in the rattling sound that we often hear prior to someone's immediate death. What are some of the challenges faced by clinicians who are involved with the end-of-life care? Clinicians, caregivers, nurses, we oversee the treatment of persons at the end of life, often facing obstacles to providing optimal care. Among the obstacles are inadequate preparation for facilitating difficult conversation. Some of us have never been trained on how to communicate with someone who's dying.
That's true.
It's a learned skill. It's an education that requires attention before you engage in it. However, in my experience, I can say that most anyone who has compassion is capable of having a conversation with a dying person that is meaningful. It is just the matter of how long you had that conversation before you suddenly realize that you need more skill than might be inherent in you as a human, compassionate individual. Another area of difficulty and challenge is insufficient compensation for giving such relational support to prepare someone for the end of life. And last, personal discomfort that I might have with death and dying myself. How do I see it? What's it mean to me?
Exactly.
These challenges must be considered alongside those faced by the individual dying or his or her supporters. All parties should be asked to contribute to the process when formulating improvement in the end-of-life care. The management of end-of-life care and the process of engaging in difficult conversations are topics that are frequently neglected in our training and our education. The conventional method of see one, do one, teach one, which is applied in the medical education area, is typically absent whenever it's related to the end-of-life care. Many medical and surgical physicians, for example, who are often responsible for getting and eliciting patient treatment preferences at the end of life, and for facilitating difficult conversations with families, receive inadequate or no preparation whatsoever for these challenging conversations. More recently, it seems that these shortcomings are being improved by enhanced clinical education and the advancement of palliative care. We nurses tend to be a little bit better educated from the get-go than I think our physician colleagues have been in the past, because of our role being very different from physicians in supporting the people we take care of.
I agree.
So the good news is education globally for all clinicians, caregivers, nurses, and so on has become more pointedly aimed at how do you talk with somebody about the issues of dying. There are certain medical specialties, such as geriatrics, oncology, and intensive care, that seem to offer stronger preparatory programs for the end-of-life care, and they encourage the recognition of death as part of a life cycle. The book I referred to you earlier in this presentation by Dr. Kellerman speaks very specifically to that notion. The title of the book itself is self-explanatory, Living Your Dying. His contention is, the moment you're born, you start to die. And death is an inevitable part of life that we can't avoid. So how you live your life while you're dying is more important than looking at life as, oh my goodness, I'm dying. It's, oh my goodness, I'm living my life as successfully as I can while I'm dying. And that's a whole different mindset. So that's good to point out. There was a study done of 230 geriatric medicine fellows revealing that 97% of physicians trained in geriatrics felt either moderately prepared or well prepared when caring for dying patients. The majority of the respondents had rotations in end-of-life care, palliative care, or hospice, and they maintained positive attitude about caring for very ill and dying patients. Moreover, they were explicitly instructed in the key concepts involved in the end-of-life care. So again, I know from experience that that whole educational process, now that hospice has become so prevalent in our society and so valuably prevalent in our society, that all caregivers and professionals are getting better educated. An issue that receives little formal attention among clinicians who care for dying people is the way they are compensated for their work. I mentioned this before. Physicians and other primary care providers like nurse practitioners and physician's assistants who care for terminally ill patients and their families are often driven by an altruistic need to ease their suffering. However, for many, altruism eventually confronts financial reality. It is reasonable to assume that continuing disparity in compensation between clinicians who spend much of their time talking to patients and families and those who spend much of their time performing procedures could lead clinicians who currently care for dying patients to get resentful. And that might prevent them and keep very talented individuals from entering the work of end-of-life care.
Yeah.
So it's well known that Medicare compensates more for invasive procedure per minute of work than for evaluation and management procedure. That, as I said earlier, is beginning to be explored and probably will be changed in the not too distant future by the Medicare system.
Hopefully.
Evaluation and management procedures include the extensive discussion with patients and families that are frequently demanded of clinicians who provide end-of-life care. More research is needed to examine whether these disparities in compensation actually lead to lower job satisfaction among the physicians and their clinicians, or whether the system has detrimental effect on care directly. Care providers frequently feel uncomfortable too confronting death because in the name of professionalism, they are expected to resist relating to or identifying with terminally ill people and their families. Gotta stay detached. Death also means the loss of the person, and this may be interpreted by some as an indication that they have somehow failed in their job. Oh my gosh, I couldn't save the man. Oh my gosh, I couldn't stop the process. Additionally, a care provider's personal anxiety about death and disease alters and incites interactions with a dying patient. In particular, doctors often think of death as a sign of failure or as an enemy rather than as a natural universal part of the process. And furthermore, a person's dying process may remind any caregiver of similar losses suffered in his or her own personal life, leading the provider to have really strong, surprisingly strong feelings toward the particular dying person. In other words, you counter-transfer your feelings onto that other person.
Yeah.
Not a good thing to happen. So what's some recommendations for us as clinicians and caregivers? There are many challenges inherent in the care of dying persons, as I said. Nonetheless, there are many interventions that do and can be performed to treat the emotional and physical symptoms of the patient at the end of life. First, we should consider in caring for dying persons to avoid thinking that there's nothing left that we can do. Often, individuals and families appreciate a caregiver for simply listening to the concerns, far more than any specific physical intervention. Additionally, such an approach will allow the caregiver to provide care that is better tailored to individual needs and their concerns. Many people are most afraid of not knowing what the process of dying is like, of pain and of being left alone at the end of their lives. The engaged caregiver can offer a great deal of reassurance simply by telling them what to expect from the dying process, and by supporting the treatment of their pain, and by promising not to abandon them at the end, and then actually following through and keeping the promise. The second consideration for treating dying persons is to recall that even at the end of life, there are many conditions that can and should be treated to improve the quality of life. In fact, among persons requesting physician-assisted suicide in Oregon, those for whom physicians made substantive interventions were more likely to change their minds about wanting a prescription for a lethal injection or lethal medication. In defining its clinical practice guidelines, the National Consensus Project for Quality Palliative Care, a consensus project of 5 national palliative care organizations who came together, outlined 8 domains of care that should be addressed. The first domain is the structure and process of our care. The work of caring for a dying person is best performed by a multidisciplinary team. It helps to distribute the task of the work so that staff can support each other during the challenging times that arise in the process of caring. The plan of care for a palliative care recipient should be a product of an interdisciplinary assessment, and it should include both the recipient and his or her family. Furthermore, this interdisciplinary structure recognizes that the care of dying persons is associated with significant personal burdens for the caregiver. Even the most experienced caregiver should rely on colleagues for help in facing difficult emotions of care and the effect that the recipient of care and their families have when they transfer their feelings and emotions to the caregiver. And it also is important for caregivers to look at, examine carefully, and accept, as well as they can, their own memories and their own feelings about losses they may have had in their personal lives. The second domain outlined by this study involves the physical aspects of care, making sure that pain, respiratory symptoms, and gastrointestinal symptoms in particular are managed aggressively while employing the best available evidence for proper outcomes. Physicians should assess pain regularly. That also should include nurses or caregivers. We should look at pain regularly, preferably with some kind of an instrument. For example, when you say to the client, on a scale of 1 to 10, tell me if 1 is the worst, the least pain, and 10 is the most pain, where do you fall? That's a very simple way to scale the pain. And anybody can ask that question. Mm-hmm. Don't have to be a doctor to ask that question. When the caregiver, the client says, or the care recipient says, I'm at a 9, well, you're not going to walk away and not treat it. You must treat it immediately in order to overcome that terrible pain that they're experiencing. Respiratory symptoms lead to significant anxiety. If anybody in the audience has ever had trouble breathing, whether it be asthmatically or it be for some other cause, you understand what that feels like. Gasping for air and feeling like you can't get enough in or you can't get it out is a challenging situation. And COPD, chronic obstructive pulmonary disease, individuals really have a hard time near the end of life.
Yes.
And also there's gastrointestinal symptoms that are often caused by the opiate-related use, such as constipation, which is a chronic problem. Mm-hmm. And if you don't manage the constipation, it makes them all the more that comfortable and can lead to very significant discomfort. It might even lead to a systemic infection.
Yeah.
In general, physical symptoms are best treated assertively, and care providers should be vigilant for signs of delirium or drug toxicity, especially in elder patients. Psychological and psychiatric aspects of care are the third domain. Often, depression is encountered in patients who are terminally ill. It can be primary, caused by pre-existing psychiatric illness. It can be medication-induced, for example, from corticosteroids or chemotherapy, or it can have an organic reason, such as the metastases of a cancer affecting the brain. In patients with terminal illness, physical symptoms can be confused with neurovegetative symptoms of depression, such as fatigue, sleep disturbance, and loss of appetite. This makes depression difficult to diagnose. Therefore, psychological symptoms, such as loss of pleasure and hopelessness, may be better indicators of depression in the case of dying people. Regardless of cause, depression is treated in a similar fashion and with judicious use of pharmacologic and non-pharmacologic treatments. Referral to a psychiatrist for further evaluation may be encouraged as necessary. Other psychiatric issues include anxiety and cognitive impairment. If recognized, many of these conditions can be reversed or at least substantially ameliorated, unless we're talking about a person who has Alzheimer's disease and is dying from that illness, or someone who has a different form of dementia, such as Lewy body's disease or something related to that, and they're dying as well. Their dementia is certainly not going to be reversible.
No.
But if it's a drug-induced dementia or a drug-induced situation, then it might be able to be tweaked or adjusted. Other domains important for the treatment and the comfort of a dying person include tending to social culture and providing attention to spiritual aspects of their life. Often interconnected, these three areas refer to successively larger spheres of connection, from the interpersonal, that is their family and friends, to the cultural, connecting to a larger set of customs, tradition, and modes of communication, and to the existential, therefore the way in which people understand their lives and deaths in view of ultimate meaning and value. Ensuring that the needs of people in these areas are attended to is a meaningful task of anyone who cares for the terminally ill. Clinicians should be feeling comfortable engaging patients around their concerns in these areas. However, they should feel equally comfortable consulting or referring individuals to social workers, chaplains, or psychologists. Mm-hmm. You don't have to take ownership of everything that you need to do for these folks. That's why the multidisciplinary team is so critically important. Only by paying attention to your own limitation can the person caring for a dying individual best serve that individual. The last two domains outlined by the National Consensus Project are caring for the imminently dying patient, and there are ethical and legal concerns. These two domains are often related, as significant ethical and legal issues surface around the latter part of a dying process. Primary care providers should do their utmost to recognize when the patient transitions to an active dying phase, and should communicate effectively with the individual and the family about their wishes in the dying process. For example, the setting of death and the intensity of symptom management. Do they want to die at home? Do they want to die alone? How do they want to die? That's really a critical fact. If these things are not discussed beforehand, making a referral to the hospice team can be an effective way to care for the imminently dying person and family. And importantly to note, you do not need a physician's permission to make a call to a hospice and offer a request for an assessment to be done on someone that you love or in someone's care, someone who is in your care. You can do that. The hospice team will then make a connection with the person's physician as needed if they deem this individual appropriate for hospice. That's something that a lot of people don't know about. That is the way it works. You can get it through a doctor, you can get it through a medical institution, but you can also call yourself and ask for it. Lastly, working with the individual and family to clarify issues of decision-making at the end of life are also equally important. Who's in charge and what's on second? For example, what are the individual's wishes? Have they written them down somewhere? Do they have advanced directives? Do they have a living will? Who will be the person's surrogate when he or she is no longer able to make any decisions? Seeking this clarification allows the dying and their caregivers to work and communicate more effectively, and helps them avoid or ameliorate ethical issues about decision-making that arise at the end of life. So in conclusion, what have we learned? The care of dying people is fraught with challenge for the individual, for the loved ones, and for care providers. Care providers must keep in mind the difficulty a patient faces if the process, as well as their own professional and personal obstacles to performing the work to the best of their ability, gets their attention. Therefore, end-of-life care is optimized when approached as a thoughtful collaboration between dying individuals, their loved ones, and whoever is caring for them. While many Americans remain uncomfortable with thinking about and discussing end-of-life options, armed with the knowledge provided today, care providers have a remarkable opportunity to help ease the physical and emotional suffering of those who are dying and of their families. And the families, remember, are also confronting terminal illness and death and have to linger longer after the person dies. And there's that whole stage of grief and suffering that occurs for many after the death of a loved one, which also can benefit from support and attention by professionals outside of the family. Grieving is a whole different topic that isn't going to be covered today, but perhaps it should be at some point in the future. We could take the time to look at that as another topic. So I want to share with you some of the resources of this presentation's content so that you know where it came from, and then I'll bring us to a close. My primary source for the presentation was an article in the Primary Care Companion Journal Clinical Psychiatry, written in 2006, and its title was Clinical Challenges to the Delivery of End-of-Life Care, written by Jennifer Wu, W-O-O, who's a Bachelor of Arts, Guy Maytal, who's an MD, and Theodore Stern, an MD. Miss Wu, at the time, was a research associate at the Columbia University College of Physicians and Surgeons. Dr. Maytal was a fellow in psycho-oncology at the Dana-Farber Cancer Institute and Brigham and Women's Hospital, and a clinical fellow in psychiatry at the Harvard Medical School. And Dr. Stern was of the psychiatric consultation service at Massachusetts General Hospital, and a professor of psychiatry at Harvard Medical School. They also had a long list of references that they cited in the paper that they wrote, which I'm not going to elaborate here, but I do have as resources if anyone's interested in further reading. So I share that with you so that you know these are not all my original thoughts, but they were put together well enough that I felt they were very useful for today's conversation and discussion. So with that I end, and thank you for your attention.
Thank you. I do have some questions.
Go ahead, Sharon.
That was all very good and informative information, so I thank you for that. I do have a question that if we could elaborate on it a little bit. You mentioned something about what creates a worsened sense of dignity for someone who's in the dying stage. Can you elaborate on that a little bit? What exactly were the points that you were making that we as caregivers need to know?
To avoid worsening the dignity?
Yes, yes.
One or two examples I can think of from personal experience is just because someone's dying, you need to respect, for example, their personal space.
Okay.
You need to respect the fact that they may have a real strong sense of modesty.
Okay.
And so when you're bathing them or you're dressing them, you're not exposing them to other people. You need to forcefully encourage privacy for the person. They don't need someone with them every single moment of the day. Sometimes that is overwhelming to someone. Some people do like that, but I think it's better to question that of the individual. You know, what works for you? How much time do you want other people to be with you? Are you okay being alone for periods of time? Things of that kinds of questions. Another thing is that if someone has a belief system that is different from ours, as I so strongly emphasized, we must permit that person to only engage in what they want to engage in spiritually. We have to avoid imposing our own beliefs on another individual. And just because we think that a certain ritual should be practiced, for example, at the end of life, doesn't mean that that person wants to accept that. And if they're unconscious and they can't respond to us and tell us yay or nay they want it, we shouldn't impose our own values on that person in their mental absence. And I've seen that done. I've seen people, perform rituals for someone who was unconscious and had either died or was at the point of dying. And I just don't personally believe that that's okay. If I happen to know what the person's rituals are because they've explained them to me and they've said to me, this is what I would like to see happen for me at the end of my life,
right,
then that's how we respect that dignity that they want at the end of life. Another one is to encourage all the time whatever minimal ability the person has to function independently. The worst thing we could do is take away someone's independence. Especially if they are still able to speak and move around and engage in conversations or engage in activity. We need to let people be individuals and to have autonomy. Those are some thoughts that I can share right off the top of my head.
And that brings me to another thought, another point. When I was working as a caregiver and dealing with someone who was on their deathbed, so they weren't cognitive and they weren't conscious, but I was aware, because I knew about this, that people actually, hearing is the last to go. So it's very important how we handle ourselves, what we say around them, even then, even when you think that they're not aware, they still can hear. So I think it's also very important for those of us that do caregiving to also, sometimes all it takes maybe is a touch, just a kind touch, showing compassion. We don't even have to say anything. That's showing kindness. That's giving them their dignity. And also even then, as you were saying before, pointing out how to be aware of the fact that just because they seem like they're not there, that sometimes they still are aware but cannot speak, and they can hear. So to be very cognitive ourselves of the fact that they need to be covered, that all these things that you just, made a point of bringing to our attention.
Something you triggered as you were talking for me is a memory that I learned very early in my nursing work. As I said, I used to be an oncology specialist. In fact, I had the privilege of being the first oncology clinician administering chemotherapy in the oncology clinic for early in my nursing career.
Very interesting.
What I wanted to say was, we have to remember that when someone is unconscious in a bed, but still not dead, and requires our care, we're not handling a piece of meat.
Exactly.
We are handling a human being who can still perceive things that we aren't even necessarily aware of. I fully agree that hearing from experience seems to be the final thing that goes. Now, we don't have any concrete proof, because someone who's dead doesn't come back and tell us they can hear us. But sometimes people who have died and been revived report that
Say
right
they were
at the
aware.
close, right at the close of the death, of the moment of the dying, they could hear. So that's kind of think where that whole notion comes from. But I think it is good to use that as a guide, that to have that as a focus, that if there's any remaining sense that still persists for someone who's dying, believe it's their hearing, because that means you can still whisper in their ear, you can still, you want to avoid harsh conversations about how you're feeling or whatever, argumentative type situations. Take that out of the room. Don't have that conversation next to the person who's in that bed. Or the other thing about it is, singing. Sometimes people enjoy soft singing, or I had one client that one person I took care of. I wouldn't call her a client. She was my friend, who was she was blind, and for many, many months I used to read the Bible to her. And on my own time, I would just go and read the Bible to her. And at the end of life, when she couldn't speak anymore, she was unconscious from the standpoint of communication, I used to still go and read her the Bible. And I believe that that was important for her. I believe that that was a way to help her ease out of life. So again, I think those are conscientious things that all caregivers need to attend to. And we have to consider our boundaries. When is it appropriate to do it? When is it not?
Yes.
So I like what you brought up there around that dignity matter.
And if you knew that that was something that she was comfortable with and wanted, and that it was comforting for her.
Yes, absolutely. I wouldn't have done it otherwise.
Yeah.
I wouldn't have done it otherwise.
So, also too, it's to be in the presence of someone who is who is dying and is at the end stage of life. It's very sobering, and it's very humbling. And it's actually very special if we can look at that, because that person is transitioning. And in other cultures, they celebrate, the death process in a whole different way than we do in this country.
Yes.
So that it is a better transition.
Yeah.
And I think all the points that you made and everything that you read was very enlightening to us as caregivers, because we need to know that this person is transitioning. And so while we're there in their presence, we need to be present in the moment with them. Yes. And I think that that's very important, and I think you made that point. And so thank you.
I want to finish this presentation with another what I consider a very important point, and that is, as caregivers, if we care for someone over a long period of time, we inevitably become emotionally entwined with that person. No matter how hard we strive to professionally detach ourselves, we will have emotional bond. As long as our relationship with that person, as we care for them, has been loving and caring and considerate. in both directions.
Right.
So having that context, I say importantly to any caregiver, it's okay to express your sentiments, your emotions at the time of someone's death. It's okay to cry, it's okay to feel the sense of loss, it's okay
Yeah.
to carry forward and attend the person's services if there are any.
So important.
All of those facets are important and they do matter at the end of life. They may not matter at the end of life for the person who died,
No,
but they
for
matter
you.
at the end of that person's life for
Yes.
you as a caregiver.
Absolutely.
So please never ever let go of the notion that it's okay, it is okay to be part of a person's death and a part of a person's life experience. It's okay. And we want any caregiver who works for TLC to feel a sense of affirmation from us that we will respect you if you want to be part of that closure that the family might have or that you need to have with that person that you took care of. So I leave you with that thought today.
And you also brought up one other point that is very important in your presentation about it's essential, teamwork and effort, getting that support as a caregiver.
Yes.
And I know TLC is very good at that. So, all right, well, thank you.
Very good. Yeah, did you push it in?